then you can add additional cosmetic surgeries, touch-ups to this area, and some of the minor scars, previous scars, vanished. This is status past 3 years, and you can see from the different angles, the color match is remarkable. Sorry. And this lady, who was a 47 years old female patient, and she suffered flame burn 40 years ago when she was 7, and multiple surgery to reduce facial scars over 25 years. And no apparent improvement according to the patient. She came to me with this appearance. And then structural fat grafting, but 2 sessions needed, 6 months apart. And you can see the significant improvement in color match. You can see the pre-op, and this is post-op 18 months. And this patient had another different kind of problem, and she had Klippel syndrome, which is hypertrophy of the lower extremity. And you can see some degree of skin color change. And the circumference of her right leg was 37 centimeters, and the left one was 32 centimeters, and there was 5 centimeters of discrepancy. What I performed, liposuction of the right leg and thigh, and liposuction of bilateral low handles, which are the lumbar area for my young fellows. And we performed ADRC isolation, that was right regenerative cell isolation with standardized cytor technology. And we performed cell-enriched fat grafting to left leg. And now I'm waiting for long-term results because I have recently performed this surgery, and I'm sorry about being unable to show the long-term result, but I'm expecting a remarkable result from this patient too. And this guy had facial asymmetry at 32 years of male patient, and he had developmental dentofacial deformity. You can see the right half of his face is, let's say, bigger, larger, longer than the left one. And this is called as the dentofacial deformity, but he had normal occlusion of his teeth. And the relationship between the upper jaw and lower jaw were normal. And 1 section of structural fat grafting of lower eyelids, left malar area, right forehead, you can see here, left cheek and left jawline. And this was pre-op, this is 18 months post-op. You can see the discrepancy between the 2 sides of the face has been diminished, and he's very happy with the result. And this lady had on the right maxillectomy, the resection of the right half of upper jaw, and ALT free flap, which is anterolateral thigh free flap, a microsurgical reconstruction for whom I'm familiar with plastic surgery, for extensive skin cancer. It was squamous cell carcinoma 6 years ago. And also she had adjuvant radiotherapy, which is another blow to the tissues. And she was complaining about contour deformity, you can see here. And this is the flap, let's say the yellowish area. And structural fat grafting was combined with unilateral facelift, skin mass facelift. And this was a pre-op picture. You can see the contour deformity, the hollow area, and this is 15 months post-op. Different angles, 15 months post-op from lateral and from right oblique view. She had a considerably acceptable result, and she was very happy with that. I didn't need any touch-up with this patient. So, meaning from context from this short presentation, fibroadipose tissue, I would like to, let's say, call fat fibroadipose tissue. It's a real source of multipotent stem cells. This is one. And growth factors are in our arsenal, and I think we will get fascinating applications in both plastic surgery and also in different fields of medicine. And patient selection is so important. You cannot perform regenerative surgery in every single kind of patient, in every, let's say, diabetic foot ulcer. You have to select patient very carefully, and surgical technique should be precise and refined. As you can see, you cannot, let's say, get this kind of results every time, but favorable results are not so far away from us, they are achievable. And this is the view of my office in Istanbul University, and you're always welcome. Any question?
Dr. Orhandovic, thank you for your impressive presentation. Could you please explain what you mean by saying structural fat grafting? I really wonder what you mean by structural fat grafting.
Sure. Thank you for this beautiful question. Structural fat grafting concept is defined by Sidney R. Coleman, and structural fat grafting work group is also registered by Dr. Coleman. And this is, I think, pretty obvious. The structural fat grafting just trying to change the tissues in both quality and quantity. For example, I showed some cases just needing volume replacement, but also some cases just needing change in texture, quality of the tissues. So structural fat grafting, which was defined by Sidney Coleman, and I worked with him for a short period of time, 5 years ago, and this was his, let's say, definition, and also it's present in his book. But I think the definition has its meaning with his results also, and I'm trying to get some good results with this technique. And also Satori technology is really impressive because it's very beautiful to get 5 milliliters of multipotent stem cells in 2 hours, let's say, and doing everything in one session in operating room. And I think also growth factor application will have a very wide, let's say, field in plastic surgery. Any other question? Okay. Thank you so much for being with me and for your patience.
Now, as we have plastic surgeons and also a general surgeon here, and our guests, I would like to have only one question just for the future organizations, and then we will close the session. For the plastic surgery operations, that is fine, because they do the liposuction and the surgeries, but for the other concepts, like if we need liposuction for general surgeon and cardiologists or vascular surgeries, how do you organize the team? Do you have a plastic surgeon for liposuction? Because you emphasize that it should be properly made, and the only reasonable complication can be from the liposuction, as there may be bleeding, anesthetical results. And to prevent this, I think we need plastic surgeon in a team, and then the stem cell manufacturing, and then the application. Is it the best way, you think, or?
It's an interesting question. We have got no particular plastic surgery department in our hospital. We've got the breast and oncoplastic surgeons who are specifically working with the breast, so I have no experience with any facial work and so on. And they have been employing the technique themselves, and they've taught me basically, and as I said, I'm doing it and I supervise always somebody at hand, with no complications so far. And I believe in our institution we didn't have any complications or major complications from the liposuction part. So we have organized it locally between the breast and oncoplastic surgeons being there, but we didn't see any particular reasons to limit it to them and to have them mandatory there. I mean, I would hope as time progresses that I'm just going to do the liposuction myself. If there is a problem, then obviously we would need. We did get a couple of very interesting cases who did have the stoma, and then obviously we have to be a bit cautious. How to take the fat. But I think as long as you're cautious and I would say properly trained in a way, I think there's no necessary sort of like limitation to plastic surgeons from our side.
If you have a patient with a huge amount of fat, it will not cause any problem because it will take 350 milliliters, it's okay. But if the patient has a scarce amount of fat, this volume means too much. I mean, you can create a deformity, you can create irregular areas or grooves, and so maybe the lean patient needs a plastic surgeon consultation at this.
Well, I would agree with you. It was for injection of the perineum or so. There's no problem. The harvesting procedure, as such, maybe our patients always were so far not too bad in that respect. If I've got any doubts, I would certainly tell plastic surgeon there to not to leave the deformity. I think that is the one risk in a very thin patient, obviously. But I would be cautious about that and choose my victims basically personally and well.
If I might quickly add something to that, because Dr. Nezrin mentioned cardiac in her question. The clinical studies that we've been involved with have all required that a plastic surgeon be present to take care of the liposuction, because apart from anything else, the challenges of liposuction in a heavily anticoagulated patient mean that it really has to be done by somebody who knows what they're doing.
Thank you. And I think Professor Işık will comment on... No? Okay.
Just comment, but no comment, I have a question. You have any experience about the cartilage problem for the fat pad stem cell?
We don't.
You heard?
I've been to France and I've heard that they were doing similar kind of like work in those lines, but there is we don't have any experience. I'm trying to get our orthopedic surgeons to be interested.
I haven't seen any literature and publication on the PubMed or something like that, and I'm curious about it. I applied the bone marrow, but how about the fat tissue?
I think it's a viable pathway to investigate. So I think there's room to maneuver. There's certainly room to expand, and because there's no expertise with the with fat harvesting, maybe you should think about the protocol and try to apply.
I could actually add something to that if I may. I'm not aware of any work specifically, but I am aware of several protocols that have been looked at to study it, none of which have started at this point. The principal challenge is that one of the major mechanisms for the regenerative cells is angiogenic, and the cartilage area is relatively avascular. So there's some evidence you could get some action in the red, maybe the red-white zones, but the white zone would be another matter. So, yeah. So that's the only thing I'm aware of at this point.
Okay, so in our team we are planning to have our plastic surgeons for our liposuction procedures, because there was a question in the morning, what can be in the consent form. In our consent form, we talk about the complications of liposuction only for this procedure. So it will be safer side to have a liposuction team for plastic surgeon. Of course, they can arrange this. Thank you for all the audience for listening to us, and all the speakers for coming here to share these lectures with us. And today our meeting is ending, and we hope for a good start and hope to see you in the future with more collaboration. And I hope we can discuss more indications and patients. Thank you. And also I would appreciate Esma Hanım to be with us today. She's a great force and motivation to us. I hope we will have all our patients like that happy in the future.